Hi, I'm Dr. Brian Shuch, Director of the UCLA Kidney Cancer Program. Thank you for joining me today. We'll be discussing an important topic about partial or radical nephrectomy for larger or invasive kidney tumors. One size may not fit all. So it's very important for us to first touch base and discuss the importance of the kidneys. Usually people are born with two kidneys, and the kidneys are responsible for filtering blood and making urine. They play an important role at clearing out toxic chemicals. Complete loss of kidney function is life-altering. Without having renal replacement with dialysis or a kidney transplant, patients would not be able to survive if they lost all their kidney function. We've long thought that it's either all or none. You either have kidney function or you don't have kidney function. But we've realized there's different stages of kidney dysfunction, and we now call this moderate loss. We call this chronic kidney disease. And we have various stages of chronic kidney disease, ranging from stage 1, where your kidney is very happy, to all the way to stage 5, where your kidney is now failed and you have end-stage renal disease. But what we've learned is the higher the stage of chronic kidney disease, the worse the overall kidney function and the worse the risks are of having a higher risk of hospitalization, cardiac events, and death. Kidney health is really dependent on the number of functional cells in the kidney. So the kidney actually, when you're born, you have these nephrons. These are the functional unit of the kidney. And you actually have 1.4 million of these nephrons filtering your blood, hanging out in this kidney's cortex and medulla. And the number of healthy nephrons dictate how healthy your kidney is. We estimate this from the GFR, or filtration rate. When you get your lab checked by your doctor, the creatinine is a measure of kidney function. And these nephrons over time, unfortunately, can be damaged. And unlike the liver, you can't regenerate kidney. What you have is what you have. And these nephrons can be lost besides with high blood pressure, tobacco, obesity. If you get close to me, I might take your kidney out. I might take part of your kidney out. And a surgeon could definitely damage nephrons, and we can kill part of the healthy part of the kidney. And with mild to moderate chronic kidney disease, your future kidney's health may be dependent on a lot of factors, including did I take your whole kidney out or did I spare your kidney, and a lot of these medical factors. So it's important for us to realize the role that urologists play in taking out kidneys. Also, it's important to recognize future dysfunction over time when you have medical issues that damage your kidney's health. So this is a graph from our friends at Cleveland Clinic where they looked at the chance of having significant renal decline. And if you did not have any chronic kidney disease before your kidney operation, or your chronic kidney disease is only related to surgery, you have very low risk of having further decline of your kidney function. But if you have medical causes of chronic kidney disease, such as smoking, obesity, maybe you have lupus, surgery, and having some of these medical factors over here, you have a much higher chance of having further renal decline over time. So I will tell you that if you have two healthy kidneys, it sometimes may not even matter if we spare your whole kidney. With a partial nephrectomy, we can basically take out just a tumor, or a radical nephrectomy where we would potentially take your whole organ. We've actually tried to do a trial in this population when there are two healthy kidneys. And as you see here, this is looking at how good the kidney is functioning, the filtration rate. You actually, if you do a partial nephrectomy, or this blue line is radical nephrectomy, as long as your other kidney is healthy, most patients over many, many, many years, you have low chance of developing end-stage renal disease. So we still like to spare kidneys with partial nephrectomies, but with time, we do recognize that with a healthy kidney and no real risk factors, most patients will be doing fine with one kidney, okay? Now, over time, things may change. And I like this graphic to discuss what will happen to nephrons, the medical and the surgical causes of damage to these important nephrons which dictate kidney function. Nephrons are gold, they're money. The more you have, the more your kidneys are healthy and happy. And if you have surgical damage to your kidney, there's me, I'm taking out your kidney, and you might lose some kidney function based on surgical loss. But how can you avoid further decline? Well, if you keep away from the urologist and you're not having any medical factors, you will have minimal worsening in your kidney health. However, Medical chronic kidney disease, these are ongoing taxes and losses, and I'm continually stealing some of these nephrons due to ongoing losses from diabetes, obesity, smoking. How do you avoid this? Well, it's important for you to minimize some of the damage by trying to have your medical issues managed appropriately, and then you can avoid having ongoing damage. Unfortunately, these continue to decline in your kidney health if you have ongoing poorly controlled diabetes. Now, the tumor management needs to understand the kidney's health at baseline and what your future risk is. We cannot treat your kidney cancer in a vortex. We have to understand your kidney health and put it in context. Because with treatment, no matter what treatment we do, a partial nephrectomy or a radical nephrectomy, you will not have better kidney function. You will have worse kidney function because in the process of removing the tumor, we're also going to damage some of the normal kidney. Now, removing part of the kidney and saving the kidney still has some loss of kidney function, and taking the whole kidney out, you're definitely losing a lot of kidney function. However, cancer is unforgiving. So if we're going to try to do a partial or radical nephrectomy, clearly we want to treat your cancer. But if we get very close to that tumor with a partial nephrectomy and we leave something behind, clearly you're going to be in trouble. So we need to be thoughtful about what we do to the kidney's health, but we also have to be thoughtful because we really want to spare your kidney function to the best of our ability, especially if you're at risk of future kidney function decline. So there's no question about what's the right option for small kidney tumors. For small tumors less than 4 centimeters, they are infrequently aggressive. Removing just the tumor with a partial nephrectomy is favored in small tumors with healthy kidneys. Okay, we rarely would spare a kidney if the kidney has failed, but for our guidelines, if you have a small kidney tumor, almost all our patients are recommended to have a partial nephrectomy. And here are our AUA guidelines, our American Urologic Association. We want to prioritize sparing the kidney with nephron sparing or partial nephrectomy. And while patients may have excellent outcomes, if we do need to take a kidney out, if the other kidney is healthy and you have low risk factors, you're probably going to be fine. However, when we go to larger tumors, okay, the larger, more invasive tumors, we know that potentially these tumors are getting more aggressive. They're more invasive. They have less spared kidney. If you do a partial nephrectomy and the tumor is bigger, I'm not going to be able to spare 90% of your kidney. Maybe only can be able to spare 60%. And I'm going to have a higher rate of complications for these larger, more invasive tumors. So I like to tell people the larger the tumor, the hotter the fire. And sometimes we have to play with fire, but sometimes we also are going to get burnt. Okay? And the question is, how risky should we get for these tumors that are larger than 4 centimeters, that are more invasive? And the question always comes down to, well, is it imperative to spare your kidney, or is it really fully elective? In some scenarios, it may be imperative to try to spare a kidney. If you have a solitary kidney, you have multiple kidney tumors, or you have really poor kidney function. In this situation, we must play with fire to spare your kidney if possible. Now, other situations when you have a healthy kidney or mild dysfunction, I can say it is elective and you can consider playing with fire, but you always may not want to take that risk. Now, larger renal tumors that are larger than 4 centimeters, again, they're more invasive and they potentially replace more kidney parenchyma, more meat, as compared to small tumors. And then when tumors like this, when they're larger, they're probably more aggressive, they're higher stage, they have a higher risk of being higher grade or uglier. So when both partial or radical nephrectomy are treatment options, we need to be thoughtful. There's never been a head-to-head comparison saying partial is better and radical is worse. In reality, most of the studies that have ever tried to do this, they are flawed. They are due to selection bias because I will choose to obviously operate on patients that look a certain way. Maybe they're healthier and more fit, and maybe those patients can tolerate a partial nephrectomy. So in these series, there's a lot of flaws. So again, no head-to-head comparison. So we need to always try to individualize risk, and there's never a one-size-fits-all approach. So again, partial nephrectomies can be done for larger tumors. And it could be more challenging, but in experienced hands, like a high-volume surgeon, you can still have excellent outcomes. But compared to smaller tumors, we know there's clearly a higher rate of complications. There's a higher rate of positive margins, maybe leaving some disease at the edge, or recurrences, meaning over time a tumor can show up and cause a problem in the future. Now, we recognize that all these series showing that partial nephrectomy leads to great outcomes in larger tumors, they're very well-selected patients. I do partial nephrectomies in tumors 8, 9, 10, 14 centimeters. However, those are patients that are very well-selected, and I chose to do them for a reason. Now, these series showing good outcomes, most of them are relatively short, meaning with time, will these outcomes still be favorable? Or will we start to see some recurrences in the future because there was some disease left behind and it came back in the future on imaging? Now, I will tell you, if offered to all patients rather than very selected patients, the question will remain, is the outcomes going to be worse? Now, I will show this. I like to draw a lot of things for my patients. And I like to show some of the considerations we have comparing partial nephrectomy in small tumors versus some of these larger tumors that may be more invasive. And when you do a partial nephrectomy, the goal should be treating the tumor, but also you want to spare kidney. You want to have the kidney be healthy. And the amount of normal meat that is left over may range from 60 to 98%. And this may vary. For a small tumor that's located maybe at the pole, I may be able to lop this off and I might be able to preserve 90, maybe 98% of that kidney's function because it's a small tumor. But the larger you get, the more invasive you get. A tumor that may be over here, taking up the whole upper pole of the kidney, replacing all that normal meat. If I have to lop off the whole upper pole, we would call this a heminephrectomy, maybe I only spare 60%. So it's very different sparing 90% versus 60%. So you have to be cognizant of how much meat can you spare. And it's going to be less for a larger, more invasive kidney tumor. Now, the next thing to consider is that there are complications. Complications can occur. All surgeons have complications. Fortunately, in someone's hands who does it very, very often, the complication rate may be lower. But there could be medical complications related to your overall health and well-being, like your heart. Maybe you have a higher risk of getting a blood clot. That's something that may be unavoidable between a partial or radical nephrectomy. But when we do a partial nephrectomy, there are clear complications that can arise when we're trying to spare the kidney. Some of these can occur due to the kidney's overall function. Well, the kidney filters blood and makes urine. So some complications like bleeding and leakage of urine can occur. And here's an example. If I'm trying to avoid where the urine collects, which is called the urinary collecting system, I can do a partial nephrectomy here, and I can avoid getting inside the urinary collecting system. I'm also away from these major vessels. But if I get deep for a tumor like this on the collecting system, I might get into that collecting system, and no matter how good I think I did in repairing that collecting system, I still may have a leak of urine outside the kidney and need a drain for an extended period of time. This is like a roofer or a plumber. They come to your house, they fix the leak, and the next time it rains, you have a leak from your roof, or still you use that sink and there's still leakage. Because we try to repair the collecting system to the best of our ability, but water or urine will find its way out. So these more complex tumors, they do have a higher rate of leakage. Now, the other thing that can leak, again, is blood. Usually for a small tumor like this, there's very minimal risk of bleeding, 1 to 2% risk of blood transfusions. But for a deep tumor where you're closer to important vessels which are coming into the kidney, you can have immediate bleeding and your risk of blood transfusion is potentially much higher, maybe up to 5 or 10% for these really large invasive deep tumors that are potentially on the vessels. Or we can have delayed bleeding, meaning several weeks later, the blood vessel and artery and vein may connect. This is called an AV fistula, arterial vascular malformation. And sometimes we see blood in the urine several weeks later, and we need to go to radiology to basically close off some blood vessels. But these bleeding complications are higher with a partial nephrectomy for these larger or more invasive tumors. So we need to be thoughtful about, can a patient tolerate some of these complications? And finally, the reason we do these surgeries is because we want to cure patients. And cancer can recur. For many of these small tumors that are maybe 2-3 centimeters, some of them are benign. Some of them are very low grade or indolent. And if you leave behind a positive margin here, there may still be a very low chance of something showing up in the future. But the larger and more invasive tumors, you potentially have a higher risk of, if you leave something behind, if I get very close to the edge of this tumor to try to spare this kidney, maybe something gets left behind that has more aggressive biological potential. And over time, there could be a local recurrence, which if left untreated, maybe it can launch an attack to other parts of the body and metastasize and lead to a poor outcome. So I will tell you there are important life lessons here that I try to tell people, that I use in daily life. I tell my wife, just because you can afford it doesn't mean you should buy it. And I tell my 4-year-old daughter, just because you can do it doesn't mean you should do it. Okay? And this comes down to a partial nephrectomy. When we see something, a lot of times we say, I know I can do it. But just because you can do it doesn't mean you should do it. You should be very thoughtful in the approach in deciding between a partial or radical nephrectomy. And when you try to see a patient, everyone is different, and you need to individualize care. And when you try to see these patients with these complex tumors that are invasive, I try to break it into 3 different categories. Well, the first important category is to understand their kidney function. Okay, what is your current kidney function? Do you have 2 healthy kidneys? What's your risk of future renal decline? The other bucket I like to consider is tumor factors. How large or aggressive is this kidney tumor? Can all the disease be reliably removed? Is there a chance that the cancer will come back? Can you actually spare the kidney by removing all this tumor? And then patient factors, age and life expectancy. So if the patient is 80, clearly they have less life ahead of them than if they're 40. Can you tolerate complications? Clearly the wheelchair has a lower chance of tolerating a complication than someone who's running marathons every week. And then are you able to medically manage some of your risk factors like your high blood pressure or your diabetes, or are you really at risk of future renal decline? Now I will tell you it's important to have a lot of tools to assess your kidney function. And if you have a lot of fancy tools, we can understand your overall health of your kidneys and prioritize what should be done. Partial or radical nephrectomy. So when we try to use these tools, I break these tools into different categories. Your assessment of your current kidney function. How is your kidney functioning now? Can we predict your kidney function in the future with some of these advanced tools? Can we help understand the biology of this kidney tumor so we understand, are we playing with fire? Is it burning super bright? And the tumor complexity, are we trying to do an operation which is going to be incredibly challenging and put you at risk? And I'll go through each and every one of these in detail. The first one will be, how can we better assess your current kidney function? Well, this landmark article in New England Journal, which is the top journal in our medical profession, really showed that cystatin C is better than our assessment using creatinine. A creatinine, when we check your blood, is how we assess your kidney health. And this paper does show that this cystatin C, alone or in combination with creatinine, will better predict your overall future kidney function, risk of complications and death. So we frequently use this in patients with poor kidney function. The other thing we commonly do is assess, well, how good is your kidney working as a filter? Your kidney filters blood, and your blood has a lot of large molecules called proteins. And the kidney's nephron and glomerulus has a filter. And if your urine has no protein, clearly it shows that your kidney's functioning well and is in good health. However, if your filter is leaky, you potentially could get more of these large molecules in, which are called proteinuria, in your urine. And we have the extent of proteinuria, which really dictates how bad of your kidney health is based on having a poor filter. And we check this thing called the urine albumin ratio in your urine, and that tells us how good your kidneys are. Now, what about your future kidney decline? Now, we can use a lot of these factors, such as, again, the current amount of protein being leaked, and also your current kidney filtration rate. We can have the ability to say, what is your risk? Green meaning you have very low risk of future renal compromise. Red meaning you have very high risk of future renal compromise. If you have kidney surgery, clearly you're going to be made worse. So it's important for us to know which group you fall into, because obviously the patients in the red or orange are going to be ones that we really worry about, and we really need to be risky. We need to play with fire if we can spare this kidney in these patients. In the other ones, I would say this is probably more elective, and we should really have a thoughtful approach. Do you really need to be playing with the fire? Now, we can assess your future risk of kidney failure. This is a nomogram where they built to try to understand, should someone donate their kidney? Obviously, a kidney donor is very different than someone who may lose their kidney for a cancer. However, you have many of these risk factors here that you can enter: age, sex, race, their filtration rate, their blood pressure, their body mass index, their diabetes, and it can spit out if you were going to be a potential kidney donor and you lost one kidney, assuming each kidney is similar in size and shape, what would be your lifetime risk of developing kidney failure or your 15-year risk? This model does not take into account what happens if you lose a kidney, but this probably goes up by a factor of 5. So if your pre-donation risk was very low, but it goes up by a factor of 5, maybe your risk of end-stage renal disease that goes from 0.2 to 1% is still meaning it's very unlikely you're going to have future renal compromise. So we use these to help kind of define what someone's future risk is of having kidney compromise. Another important factor, all my patients ask me is, Doc, how do you know the other kidney is working well? Well, we do have some fancy tools. One of them is using CT volumetrics. We can actually go through your scan and see how much of your kidney is taken up. And here's an example. This other kidney looks healthy, is outlined by the red. And this tumor here has taken up this portion of your kidney. So we can actually look at the volume by split function, your right versus your left, and say maybe that your right is carrying 60% of the load, and your left is carrying about 40% of the load. What we do know is there are other tools as well. These are older tools that are less fancy, but they are renal scans. We use nuclear medicine scans called renograms. They work on basically like in one X-ray shot, and they see how your kidney's taken up contrast. It's another way that we can assess renal function with older technology, and we can come up with a split renal function. We do know that your other kidney will hypertrophy. So there's a model which accounts for your other kidney if it's lost, it hypertrophying, meaning it gets stronger with time. If I lost my left arm, my right arm is going to do all the work and it's going to get bigger, okay, and there's some hypertrophy. But understanding the split function between the right and left may help us make an even better model. This is work from our friends at Cleveland Clinic where they looked at the predicted future blood filtration rate and look at the reality there over time. And you see that they're very similar. There's a linear relationship. So this is a very accurate model at assessing what your future kidney function will be using the understanding that there is going to be some hypertrophy of the other kidney and understanding your split function between the right and left side. The other aspect is for us to understanding when we play with fire, how hot is this fire burning? How aggressive is this tumor? Is it nasty or is it more lower grade and more indolent? Because if I do a partial nephrectomy, I'm going to have to get very close to the edge if the tumor is very deep and central. Now, one thing which is easy to do is a biopsy. A biopsy was when we stick a small needle in under radiologic guidance into this. This is a lady with a 5-centimeter tumor. She was considering a partial nephrectomy electively. We take a needle biopsy, we put it on a slide, our pathologists look at it, and they tell us, is the tumor, what type? Is it a nasty tumor? What is the grade? Does it look high grade? Does it look to be something that is going to probably want to hurt you really quickly? Or are there any high-risk features? When we do that, we don't worry about seeding or spreading of cancer cells. That's more a myth that rarely happens. But in some context, it may help us understand more about the biology. Now, the other thing that can be done is getting as much information on the imaging. Now, kidney tumors are not just things that we see on a scan. There are living structures with blood supply. And when we put an IV in your vein, we give you a tracer, and the blood vessels either light up very quickly or they light up very slowly, or some are brighter, some are not so bright, and every kidney tumor has a different vascular supply. So this is a picture from our colleague Dr. Raymond here at UCLA, where he characterized the kidney tumors based on imaging features, and he can, with fairly good accuracy, pick out the tumors based on the subtype or histology, based on how they enhance, how quickly, and to what extent. And again, there are different clinical behaviors associated with these tumors, so we should be expecting that they have different imaging characteristics. We also have a new scan that is moving to the clinic. I participated in this trial. It's called the Zircon trial. We used a novel PET tracer. Normal PET scans don't work in the kidney, but this is something which binds to an antigen on the surface of clear cell kidney cancer, and if present, these tumors will light up very bright and will tell you if it's a clear cell kidney tumor. So we think this may be moving to the clinic. The trial was positive, and the company is bringing to the FDA to see if it will be approved for use. Now finally, we can also assess the complexity. Is this partial nephrectomy going to be really dangerous? Am I going to damage critical structures? Well, sometimes when a surgeon is looking in 2-dimension, they may not see things. So there's a couple companies that have developed 3D software to have you use maybe a virtual headset. This was a project from UCLA, a company which is spun out called Sevra, where they develop 3D models where a doctor can take the 2-dimensional imaging and put it into a 3D model, wear a headset, and actually see how this tumor is in location to the collecting system, to vessels, and maybe help us understand how complex that partial nephrectomy is really going to be. Now, I just want to review final case studies to help you understand how I use some of this information to decide and individualize whether someone should get a partial or radical nephrectomy. A couple case series here which I think will illustrate how we think. Now, this is a 60-year-old male who had a moderate amount of chronic kidney disease. He's on 2 drugs, and he was found with a 14-centimeter mass. Clearly, most people would not do a partial nephrectomy. But as you see on this patient, there is a lot of healthy kidney here, and the kidney tumor is very peripheral. I can spare a large amount of this without going too deep, and I'm not worried about. I also thought this tumor probably was going to be papillary on the imaging. I thought it was going to be a little less aggressive. In this case, I did an open partial nephrectomy because the tumor was so big, I didn't want to have to move it around with the Da Vinci robot. So I made an incision and I did a partial nephrectomy, and look how much normal, healthy kidney is preserved. And here's the resection bed. And I chose to do a partial nephrectomy, and this patient had a very good outcome. But this patient, I felt it was safe and it was beneficial. Now, here's another patient who was a little bit more complex. This patient is 70, has significant chronic kidney disease, and they were on 4 drugs for their high blood pressure. They have a real risk of developing future renal decline and ending up on dialysis, especially if I take their whole kidney out. And they have proteinuria showing that existing kidneys are leaking a lot of this protein, meaning that they're at risk of really future, they're in that red area. However, this tumor is 6 centimeters, and I'm looking on this scan, and there's this knuckle of tumor going into a deep vessel. So I expected this was invading into a segmental vein of the kidney. We made sure there was no metastatic disease, and we offered this patient a partial nephrectomy. I said, I need to play with fire here because this patient is going to have end-stage renal disease in the next few years if I take their kidney out. And here's what we found. We did a partial nephrectomy, and again, this long knuckle of a well-encapsulated tumor thrombus was found inside that vein. But we fished it all out, we closed that vascular space, and I think the risk of recurrence, I explained to them, is probably 5 to 10%. They have a risk of recurrence systemically, but I feel like we spared their kidney function, and that person's GFR really didn't change that much. It went down maybe 5%, and I think we had a good outcome here. But only time will tell to make sure this tumor doesn't recur. Finally, another patient that we saw recently, 70. She had mild chronic kidney disease, and she was only on 1 drug for hypertension. I said I could spare your kidney. This kidney tumor does go a little more centrally. I'd probably have to take the whole upper part of the kidney. But we biopsied the 6-centimeter mass, and the biopsy showed this tumor was really nasty. It was a grade 4 clear cell kidney cancer, meaning if I was going to do a partial nephrectomy, I'd probably have to get very close to this high-grade tumor, and I may, and the patient may get burnt with time. And this patient wanted no part of increased risk of local recurrence or complications. So we did a radical nephrectomy. And when we do a radical nephrectomy, we take all that fat encasing the kidney. And you see here, you see this is actually the outline of the kidney, but all this fat is here contained, hugging this tumor. So I don't even see the kidney tumor, and we remove it, and patients have a very low risk of local recurrence. So she chose a radical nephrectomy, and as predicted, the tumor was very high grade, infiltrative, and her kidney function was sufficient, and I think over time, with good blood pressure management, I don't expect her to end up on dialysis or anywhere soon, or even having high grade chronic kidney disease. Now, I will tell you that sometimes you need to call an audible. And even the best planning, sometimes things change. So Peyton Manning was a great football player, a quarterback. He would read the defense. He would see what the defense is giving him. Sometimes you're planning to do a running play, but you see what the defense calls for, you might want to say, I'm going to throw the ball instead. When you do a partial nephrectomy, sometimes you need to make a game time decision and call an audible. And when we're doing a partial nephrectomy, sometimes we have things that go through our head, and we sometimes need to decide whether we need to convert to a radical nephrectomy. And sometimes, there's a good saying is everyone has a plan until you get punched in the face. Sometimes these tumors can punch you in the face because they are unexpected. And when you are operating and trying to do a complex partial nephrectomy, you want to make sure in your order of priority, first and foremost, my highest priority is oncologic outcome. I need to remove this tumor. I need to cure this cancer and give the patient a shot at cure. That is our biggest priority. Second, if I feel like that is going to be compromised, I will have to obviously change my approach. But I would then want to do as best functional outcome as possible. I want to spare as much of this tumor kidney as possible. I want to try to leave as much kidney behind. Sometimes I might need to take more and more and more of the kidney, and then I lose more and I have less function. But again, those functional outcomes are our second priority. Finally, the cosmetic outcomes. We try to do everything robotically, but if we need to make a larger incision, if you're not ready for the beach in the summer, so be it. But that's our third priority is cosmesis. So again, oncological is number one. Number two is our functional outcome. Number three is worrying about cosmesis and small incisions. And those sometimes are how we think about when we need to call an audible. Now here's just an example of an audible I called at the line of scrimmage. I knew this patient had risk of kidney issues in the future. He was 78, he had moderate chronic kidney disease, and he had chronic congestive heart failure. And over time, I was worried, he had 2 drugs for hypertension. He had no proteinuria, but he had a 5-centimeter renal mass. And I wanted to try to spare his kidney because I knew over the next 5 or 10 years of life, hopefully at 78 with a bad heart, he will live 5 or 10 more years. But I wanted to take a shot at sparing his kidney. And I booked him for a partial nephrectomy with the understanding is if I get punched in the face, I might need to change the plan. And this was a tumor right here, that right here in red, there was a little segmental part of this tumor invading in this vein. And we knew we were going to need to fish out this tumor from this vein. However, when we got in there, it wasn't just one segmental vessel. You see right here, there are 2 segmental vessels that are from this tumor invading deep. I tried to fish them out and try to get around these segmental vessels, but they started fracturing, and I was worried that we were going to leave some disease behind, which is not an outcome which anyone wants for a tumor which is likely very aggressive. So we need to call an audible, and we ended up taking up his whole kidney. This patient now needs to have his medical kidney health really managed by a nephrologist to make sure his blood pressure, cholesterol, and other factors minimize his risk of future renal decline. But again, oncological priority took precedence here. So for tumors that are greater than 4 centimeters, I will tell you if a partial or radical nephrectomy are both options. If you see a high-volume kidney surgeon and they tell you that they both are options, you should always hear about the pros and cons of both. I tried to outline them here today. A discussion should include why one approach is right for you. And understand that every patient is so different and we need to individualize care. And we need to understand and explain to you what we feel is in your best interest. Sometimes the approach may change. Sometimes we need to call an audible and have it be a game time decision. So I will leave you with these closing thoughts. Clearly, kidney health is important. Being on dialysis is life-changing. Being hooked up to a machine 3 times a week is life-altering. If I feel you're going to get there, clearly that's a problem, and we need to be thoughtful. Here is me doing a kidney transplant with Dr. Gritch, who runs our kidney transplant program. In training, I did about 100 kidney transplants. I will tell you that kidney transplants also are life-altering. You need to be on immunosuppressive drugs to keep you off dialysis. So clearly, this was in the LA Times, clearly we recognize that kidney health is really important, and we want to do whatever we can to spare your kidney function. However, we have to understand that sometimes we have patients that have cancer, and if we get too close to the cancer, bad things can happen. And we get referred in patients who, in hindsight, maybe their doctor made the wrong decision. This was a patient who had a normal healthy kidney. They have 2 healthy kidneys, but had a 6-centimeter renal mass. And we see this often where, patients end up having spillage of their cancer. It recurs. Had this patient had a radical nephrectomy, which is maybe what I would have done for this patient had I seen them initially, maybe they wouldn't be faced with a situation where they need to go on systemic therapy and are probably likely to die of their kidney cancer. Recurrences have consequences, and we obviously don't want this situation either. So this is a famous statue by Rodin from 1904. It's called The Thinker. I like to tell patients this is me trying to contemplate what is going to be your best approach, a partial nephrectomy or a radical nephrectomy. And when they're both technically feasible, we need to do our best to figure out what is right for you. Thank you so much for your time. You're always welcome to visit us at UCLA. If you have a kidney tumor, we have a big team. It's been in existence for 30 years. We'd love to help you in any way. Here's some information about our program. If you want more information, we have a lot of video resources available. We've taken a lot of time to curate a lot of content at our Video Resource Center. If you hover over that QR code, you might be able to access our library. We have a lot of research that goes on at UCLA. These videos take money to make. If you'd like to support our program and help us make more videos and help us fight kidney cancer, hover over this code as well, and it'll give you instructions how to help our kidney cancer program. Here's some more information on uclahealth.org about our program and some treatment options and our many kidney cancer providers. Thank you so much for your time and attention today, and thank you for letting us join you.